Hello everybody, welcome to our YouTube channel Number 1 Doctor. Today we'll talk about surgical hypertension as a part of our short medical notes series. 1. Primary hyperaldosteronism. Can be caused by an adenoma or by hyperplasia. In both cases the key finding is hypokalemia in a hypertensive, usually female patient who is not on diuretics. Other findings include modest hyponatremia and metabolic alkalosis. Aldosterone levels are high, whereas renin levels are low. Appropriate response to postural changes: more aldosterone when upright than when lying down suggests hyperplasia, which is treated medically, whereas lack of response or inappropriate response is diagnostic of adenoma. Adrenal CT scans localize it, and surgical removal provides cure. 2. Pheochromocytoma is typically seen in thin, hyperactive women who have attacks of pounding headache, perspiration, palpitations, and pallor, at which time they have extremely high blood pressure. By the time patients are seen, the attack has subsided and the pressure may be normal, leading to a very frustrating lack of diagnosis. Patients who have sustained hypertension are easier to diagnose. Start workup with 24-hour urinary determination of vanillyl-mandelic acid VMA. Easy to do, but may give false positives, metanephrines more specific, or free urinary catecholamines. Follow with CT scan of adrenal glands or radionuclide studies if looking for extradrenal sites. Tumors are usually large. Surgery requires careful pharmacologic preparation with alpha blockers. 3. Coarctation of the aorta may be recognized at any age, but patients typically are young and have hypertension in the arms, with normal pressure or low pressure, or no clinical pulses in the lower extremities. Chest X-ray shows scalloping of the ribs, erosion from large collateral intercostals. Spiral CT scan enhanced with intravenous dye-CT-angio is usually diagnostic. Surgical correction is curative. 4. Renovascular hypertension is seen in two very distinct groups: young women with fibromuscular dysplasia or old men with arteriosclerotic occlusive disease. In both groups hypertension is resistant to the usual medications, and a telltale faint bruit over the flank or upper abdomen suggests the diagnosis. Workup is multifactorial, but duplex scanning of the renal vessels and CT-angio have prominent roles. Therapy is imperative in the young women, usually balloon dilatation and stenting, but it is much more controversial in the old men who may have short life expectancy from the other manifestations of the arteriosclerosis. Thanks for watching. Please like and share. With my best wishes, Dr. Ahmed.